Good evening and welcome to the Community Wellness Partners William and Rita Abraham Speaker Series. My name is Allison J. Swartz, Parkinson's Program Director for Community Wellness Partners. In front of you, you will see a save the date flyer for our Parkinson's Awareness Walk on Saturday, September 12th. So think about forming a team. This is a great way to honor you and your loved ones, as well as a way to raise dollars for our Parkinson's programs. You will also see a flyer with a QR code and a dinosaur. Please scan this code which will lead you to a donation page on the Community Wellness Partners programs page for Parkinson's. Any amount helps us offset costs for people who have Parkinson's, allows them to participate in our programs, which are also listed on flyers on your tables. And before I announce this evening's presenter, I'd like to introduce you to Dr. Jeremy Rutter. He's our Chief Executive Officer for Community Wellness Partners. Jeremy.
Thank you, Allison. Thank you, everyone. Welcome. Glad to see such a great turnout. This should be a wonderful night and a wonderful event. As Allison said, this speaker series event is brought to you by Community Wellness Partners, but more importantly, it's brought to you by our very generous donors. So thank you to Bill Abraham and the Abraham family, who've been great supporters of our Parkinson's program. In addition, the Bank of Utica also supplements sponsorship of our speaker series, and so thank you to the Bank of Utica as well. So those who don't know Community Wellness Partners, who we are a faith-based network of nonprofit organizations, and we support wellness through the provision of community services, housing, and health care. You may know us as the Presbyterian Home, the Lutheran Home, Crestwick Glen, but we're much more than that. We, in fact, are one of the largest nonprofits in the state when it comes to caring for older adults and people with disease. We cover a geographic area from Oneida County, Herkimer County, all the way up to Old Forge and Oswego County. And we have 25 different service lines. We care for about 1,200 people every day, including those in our outpatient Parkinson's programs. So thank you again for coming, and thank you for supporting our Parkinson's programs. You can get more information at the desk here, and at this time I'll turn it back over to Allison to introduce our speaker.
Thank you, Jeremy. I'm going to jump right into Community Wellness Partners Parkinson's services. Once a person is diagnosed with Parkinson's disease by their primary care physician, they refer their patient to a specialist. But to see the specialist may take, 3 to 6 months? At Community Wellness Partners, we have a number of programs, free or of very little charge in the meantime and in the long term. They are the following: Cycling with Parkinson's, which is an 8-week program held in the fall and spring on stationary bicycles. Lee Silverman Voice Therapy, Big and Loud. And some of you, I think, are enrolled in these programs currently. These are effective treatments for people in all stages of Parkinson's disease. Big helps people with Parkinson's improve mobility and daily living activities. Loud helps with speech and communication. Rock Steady Boxing, a non-contact boxing program using sport mannequins that aim to improve the quality of life for people with Parkinson's disease. We this year started a Nutrition for Parkinson's program, which is held in the spring and in the fall. It's an 8-week program that discusses how to eat better for brain health. And Pat Sells, who I'd like to recognize here, she's taught our nutrition classes this past spring and will be again this fall. Thank you, Pat. Finally, each month we host a Parkinson's support group that meets on the third Tuesday of each month. And I want to also recognize and thank Rosemary Taylor, who is also here, who helps facilitate this program. Thank you, Rosemary. Did you know that Community Wellness Partners is a certified Parkinson's disease care business? 4 of us at Community Wellness Partners completed a certification with the Parkinson's and Movement Disorder Alliance. And we've been a certified care business since February of 2025, and you probably saw that on our commercial. The knowledge that we gained and having passed a rigorous exam earned us the certification of Parkinson's disease care advocates and Community Wellness Partners as a certified Parkinson's disease care business. And so only 2 other organizations in New York State that have these same credentials. One is located in Long Island and the other is located in the lower Hudson Valley. We are the only one in the upper 3/4 of New York State. I also want to recognize our Parkinson's team. The Community Wellness Partners Rehab Therapy team has some awesome Parkinson's numbers to share. And I want to just recognize Kelly and Dee, who are in the back, at an information table. So if you are interested in any of our programs and want to sign up, they're here to answer any questions that you have, and they'll take down your names and telephone numbers for us to reach out to you to set up an appointment. So overall, so let me just talk about our symposium. Some of you attended our symposium back in April, and I want to mention that 27 new people are now enrolled in our Lee Silverman Voice Therapy Big program as a result. So you've come to the right place. So overall, these folks who participate in this program see the following: 53% improvement in balance, 137% improvement in endurance, and 281% improvement in strength. So that's something very important to know. You can live better with Parkinson's disease. So our Parkinson's team includes Trevor Gates, Doctor of Physical Therapy, who specializes in LSVT Big, who just had a baby, so you might see him next week, very tired. Julia Downing, also a Doctor of Physical Therapy, specializing in Big as well. Katie Conway, she's our speech language therapist. Dee Hameline, Physical Therapist Assistant, hosting our PT table this evening, with Kelly Bowden, Physical Therapist Assistant. And we also have Maureen Ferrugia, who's been in the fitness field for more than 40 years, and she teaches our Rocksteady boxing. So please visit the information table. Feel free to sign up for any one of our programs. All of our business cards are also on that back table if you just want to capture our information and then call us, at another time. Also on your tables, there are slips of paper for you to place your questions on. So if you have questions before our speaker finishes his presentation, get your questions ready, and then someone from our team will run them up so that we can get them all asked and answered for you. If we cannot get to your question today, we will make every effort to get the question answered for you. So give us a week or two to get those answers for you, and we'd be happy to do that. Dr. Octavian Adam. He received his medical degree from Carol Devila University of Medicine and Pharmacy of Bucharest, Romania. He completed a fellowship in movement disorders at Baylor College of Medicine in Houston, Texas, and his residency in neurology at the University of Texas Medical Branch at Galveston. Dr. Adam has been in practice for more than 17 years. He has expertise in treating Parkinson's disease and other movement disorders, dementia, and other neurological disorders. He is currently the Chief of Neurology at the Albany Stratton VA Medical Center, is also an Associate Professor of Neurology at Albany Medical Center. and he practices neurology at both locations. According to patients' experience with ratings, and so we do a little bit of research on who we have come to speak, he has received 5 out of 5 stars, which means that his patients expressed a high level of satisfaction with him, including being knowledgeable, caring, and thorough in his explanations. His patients appreciate the time he provides to listen, and they value his expertise. So I'd like to introduce our speaker, Dr. Octavian Adam.
Hello, everyone. And thank you for having me over tonight. Thank you, Allison and Jeremy, for inviting me to speak today. I guess the questions will be at the end, but if anyone has any burning questions, feel free to raise your hand, and I'm going to do my best to see you and answer it on the spot. Let me see what the clicker is. Power way up. All right, so I just want to get a few basics out of the way, just because I'm going to be referring to certain words, and it's always nice to sort of speak the same language, so to speak. So Parkinson's is a brain condition that makes it hard to control movements. It's primarily a movement disorder, but not exclusively. Common motor symptoms include tremors, stiff muscles or what you call rigidity, slow movement, what you call bradykinesia, and gait and balance changes. And there are a lot of non-motor symptoms which I'm not going to really go over today, but a lot of times present more disability than the motor symptoms in some people. This is just sort of a schematic of the different stages of Parkinson's disease. There's a pre-symptomatic stage when the condition begins in the brain, but there are no symptoms yet, or the symptoms may be very mild, almost unnoticeable. And that can last for years or even decades sometimes. Then once the diagnosis of Parkinson's disease is made when the first physical symptoms appear, so the ones we sort of refer to, the tremors, the stiffness or changes in gait or balance, and that's when the diagnosis is made. Early on in the diagnosis, most people have mild symptoms that may or may not require medications, or the medications do a good job controlling the symptoms, and we call it the honeymoon period. And that can last, there's a great variability in how long that lasts. And at some point, as Parkinson's being a progressive condition, the next stage would be what I call the moderate stage, and that's kind of what I'm going to focus on today. And in the moderate stage, the symptoms progress to become a bit more disabling or to affect someone's functioning to a greater extent. And oftentimes it requires tweaking the medications or using treatments that are not exclusively pills. I'm going to talk about what we mean by on time and off time. On time is the state when the medication is working well and the symptoms are controlled well, meaning the movements are easier and smoother, there is less stiffness and shaking, and it is easier to get up and walk. The off time is when the medication effect is low, which means that the movements are slower, there's more stiffness, more tremors, and it is harder to get up and walk. Now, wearing off means that the medication effect fades off before the effect of the next dosage of the medicine has time to kick in. And it feels like the symptoms gradually turn near the, or return near the end of a dose. And motor fluctuations means that there's a sudden or unpredictable change between the on state and the off state, and that can sort of repeat itself multiple times a day depending on how the medicine is timed or taken. And examples include a sudden freeze, or experiencing sudden off symptoms, or the movement symptoms can sort of switch unpredictably between the good on state or the bad off state. And these changes may or may not be predictable, and they may or may not match the timing of the medicine. Dyskinesias are involuntary movements, what we call unwanted movements, other than tremors. And the best I can sort of explain it is if you picture Michael J. Fox that all of us have seen on TV on multiple occasions, and the way his body kind of wiggles and twists and turns and is in constant motion, that's what we call dyskinesia. And that would be sort of an extreme example of how these unwanted movements take over one's body. And that is typically caused by medications, specifically medications that target dopamine in the brain. And again, may look like twisting, fidgeting, or dance-like movements. Dystonia, which is at the bottom of the page, is a bit different than dyskinesia in the sense that it's more of a twisting, sort of turning, sometimes crampy movement that typically affects a foot or the toes or maybe a hand. And that can happen from having Parkinson's and may or may not be related to the medicine. So I kind of went over these sort of concepts because these tend to be or potential problems in this moderate stage of Parkinson's disease that we try to address with treatment. And why do these symptoms come on in this moderate stage? Well, first of all, this question comes up quite a bit in the office. People with Parkinson's will ask, how long is this medicine going to help me? Is the medicine at some point going to stop working? And what happens in this moderate stage is the response to the medicine becomes shorter and shorter or less consistent. So even though one would take the same amount of medicine every 6 hours, let's say, the response after each dosage may not be as consistent or the same or predictable every time. So we end up with these problems of fluctuations and dyskinesias or off symptoms. And that happens because Parkinson's progresses. It happens because of variable intestinal absorption. When the stomach is full or with this constipation, the medicine may not get absorbed to the same extent or as fast or as slow the same every time. So what's important to us in the office as a provider is understanding or teasing out whether or not these symptoms are a sign of too much medicine, like dyskinesias and picture Michael J. Fox, or too little medicine, right? Because that's going to help us to troubleshoot and adjust the medications just right. So it's important to keep a journal of these symptoms and their relationship to the timing of the medicine. And, focusing on the symptoms that are most bothersome is usually important. So how do we sort of troubleshoot these problems? Well, first of all is, I always tell my patients, I'm not the one living with Parkinson's, so it's hard for me to understand how, the symptoms vary throughout the day and how the medicine affects, these symptoms from hour to hour. So I usually encourage patients to sort of experiment a little with the medicine in the sense that they may sort of experiment with the timing of the medicine or maybe the dosage within certain bounds. And it's our job to sort of discuss in the clinic, what are these bounds of changing or experimenting with the medicine a little bit at home, because that's probably one of the best ways of figuring out what works and what doesn't. And it's also important when you go and see the neurologist and when you explain, these symptoms that you may be experiencing and may be bothering you, what other medications may be available other than the most commonly taken medicine, which is carbidopa-levodopa, which most people with Parkinson's disease end up taking. And there's a variety of other medications and may or may not be appropriate for each individual, but there are what we call helper medications, or medications we add on to carbidopa-levodopa to sort of improve symptoms. And we also call them extenders. And there's a variety of them, and I just listed them down here under their real name and brand name. And these include entacapone, opicapone, selegiline, rosagiline. So there's a number of them that can sort of make levodopa last a little longer without actually having to increase the dosage of levodopa. There are longer acting dopaminergic or dopamine-based medications as well, such as dopamine agonists like pramipexole or Penarol. There's a patch called Octavian, and there are other medications that have a completely different mechanism and can be complementary to carbidopa-levodopa, such as isradiphyline to add more on time. So again, we try to troubleshoot by changing the dosage of carbidopa-levodopa, the timing, the type of levodopa, or sometimes add helpers, extenders to levodopa to make it last longer, be more effective. Now, how do we troubleshoot dyskinesias? Again, dyskinesias being those unwanted, excessive body movements that look like someone is really in constant motion, they're fidgeting all the time. And it's important to sort of, first of all, what I just did today, kind of make sure that we're speaking the same language, because when I say dyskinesia, the person may not know what that means, right? So it's important to sort of describe the symptoms or the movements that are bothering you, so that we understand what that symptom is. Now, not every dyskinesia has to be treated. Sometimes they're mild or they're fleeting. They may last maybe just 10 or 15 minutes and they go away. So in that situation, we choose not to treat them and just leave them alone. But if they're occupy a great proportion of the time, or if they're disabling or severe, then we'll treat them. And the first step is really to look at the medication list and eliminate medications that can potentially bring on or make dyskinesias worse. And that's probably the first step before we add, right? So we subtract before we add. And examples of medications that can increase dyskinesias would be entacapone, opicapone. Sometimes less is better. We also, if that's, once we're past that one step of eliminating what's not needed or what might maybe making dyskinesias worse, then we think about other medications that, when added on, might make dyskinesias better. And I listed a couple of examples, which is amantadine, or the extended version of it called Gocovrin. Now, how do we address what I call wearing off? So wearing off is that problem where the off symptoms, the Parkinson symptoms, return at the end of a dose before the next dose has a chance to take effect. And this wearing off can be a gradual process or can be a sudden process. It doesn't follow the same timing for everyone. So when the wearing off, so the return of Parkinson's symptoms is unpredictable, then we use what we call rescue medication. So imagine you're out and about, let's say at a restaurant, and you're having a good time, and all of a sudden you feel like the symptoms come back and they accelerate over minutes, right? And you're not expecting that because you just took a medicine, let's say, an hour ago, right? And you're feeling good. This is what we call an unpredictable or sudden off episode. So there are options. One of them is a levodopa inhaler, which looks like a regular inhaler, and that can be used fairly quickly, and it kicks in very, very quickly, probably within 10 minutes. So that's a nice sort of option to have if this problem reoccurs frequently. There's also something called apomorphine injection, apomorphine, which has nothing to do with morphine, the drug. But that's another option, as an injection to reverse that sudden return of the off symptoms. If the wearing off symptoms are more predictable and you know that you're out and about and maybe the symptoms come back maybe half hour before the next dosage, you could move the next dosage up, so take it earlier, or if it's kind of in the middle, you could use just the oral levodopa on a as-needed basis for when this happens. Since for these problems in the moderate stages, meaning the fluctuations and the dyskinesias, and I'm going to cover what we call continuous infusions. These are pump-based, and deep brain stimulation, which is surgery, and also the MR-guided focused ultrasound, which has gotten a lot of press lately. Also another surgical procedure that's non-invasive. So this levodopa pump was approved about a year ago, or maybe a year and a half ago, and delivers a version of levodopa subcutaneously, or what we call under the skin. And it has two advantages. One advantage is the fact that it provides a continuous delivery, as opposed to the oral, which you take every so many hours. And it bypasses the gut, right? So it's not going to interfere with any kind of, or its absorption won't be affected by food that's already in the stomach or the intestine. And that presents advantages for the way it controls the symptoms. Despite the name pump, no surgery is required. The pump is external, and you can actually see it sort of attached to the belt in this picture. And what we call the needle that goes in the skin is called a cannula. And you see that white little sticker on the skin. So that has a needle that goes through about 6 to 9 millimeters under the skin. And that's what we call a cannula. And it's usually applied every 1 to 3 days. So you put the sticker with the needle on, you connect the pump, and then when you're done with the pump, let's say at the end of the day, or maybe when it's time to refill the pump, you disconnect the tubing, the pump from the cannula, the needle, and the cannula can stay in place for up to 3 days. And if someone were to go on this pump, it replaces the oral carbidopa levodopa, so you wouldn't have to take the oral medicine. The pump takes over all the levodopa needs, essentially. And there are preset rates that the pump has that the provider normally sets during the clinic visit. And there are several options for rates. There's options for extra dosages because you recognize that, again, not every day is the same. And a person who uses this pump can switch between different rates, higher rate or lower rate, depending on the needs in the day. There may be a low rate at night and a higher rate during the day, so it kind of varies depending on the need. This pump, again, the brand name is Vyalev, may be left on for 24 hours. Not that it has to be on for 24 hours, but it can be left on for 24 hours, so night and day. Potential problems are cost. The infusion site reactions, which are quite common, where there may be redness or stinging feeling when you put the needle through the cannula, or maybe bruising, sometimes infections. So site care has to be very deliberate, very careful. And it's important to work with your neurologist to sort of optimize that rate that we talked about. And I've had patients where, initially had quite a few visits, sort of optimizing the rate, and eventually once that's all settled, they did very well. And I think the patient that I have on this pump that's been using it the longest now has been using it for probably a year and a half. Now, there's another pump, so we're moving on to another pump called Onago. This one delivers the medicine the same way under the skin, but it's not levodopa the way the first pump uses, but it's a medicine called apomorphine, which acts on the same dopamine system in the brain, but it's different than dopamine a little bit. Same concept, no surgery required. The pump is external. It has the same, essentially the cannula, the needle is identical between the two pumps, but the pump itself looks a bit different. And this infusion, as opposed to the first one replaces the oral carbidopa-levodopa. This infusion is typically added on to carbidopa-levodopa. So someone would, one would take their oral medicine plus the pump to smooth out any kind of fluctuations and ups and downs in their symptoms they might have during the day. This one is approved for continuous infusion over 16 hours, so it's not left 24/7. It stays on during the day and essentially comes off during the night. It's got a fixed dose that's not adjustable, and it carries the same type of potential problems of infusion site reactions. And because this one is added on to the oral carbidopa-levodopa, there's a risk of sort of overloading the system, meaning too much medicine, too much oral, too much infusion, where side effects can sort of pile up. And those would be dyskinesias, right, so too much movement, or even hallucinations. So it's important to work with, again, your neurologist to optimize that rate. Luckily, this pump has a very robust program in place where a nurse typically comes to the person's house whenever needed, once a week, once every other week, and they actually can tweak the rate to optimize the response. So you're not sort of left on your own in the dark, but there's someone who watches over and comes at the house and helps optimize that rate so that the pump does what it's supposed to do, and meaning make life better. Now moving on to deep brain stimulation. This is a surgery, brain surgery, again indicated for to control the symptoms. They become disabling in that sort of moderate stage. Those fluctuations from hour to hour, or in symptoms, or sudden off episodes, or dyskinesias. And this is normally done when, no matter what changes we make and all the other medications or pumps we tried, we can't reach that sort of good response that would translate into good quality of life. And ultimately, this procedure is not to cure Parkinson's or to slow down the progression. Its purpose is to improve quality of life by addressing the most bothersome symptoms that one might have related to Parkinson's. And it can address off symptoms such as slowness, stiffness, tremors, dexterity problems. Can address on symptoms, those dyskinesias, those excessive movements we talked about, or fluctuations, these sort of changes from hour to hour in symptoms that are hard to control with medications alone. This DBS has been around for quite a while. It was approved for Parkinson's in the late 1990s. So there's a lot of collective experience with this therapy. And there have been many studies that follow patients with Parkinson's for decades with this therapy. And we know that when done properly and when done at the right time, it can make a huge difference in someone's quality of life. And just to give you a metric, it can decrease the off time, right, so bad symptoms, by about 4 hours a day, which is quite substantial. And the way it works is there is a electrode that's implanted through a hole in the skull, deep in the brain, in the part of the brain that's affected by Parkinson's. And this electrode is then connected to a battery pack, a little computer that's implanted under the skin, under the collarbone. And the two are connected through an extension wire that's travels from the surface of the skull under the skin down to the chest area where the battery is. So we have these three components: the electrode in the brain, the extension wire, and then the little pulse generator, we call it, in the chest. This is just a schematic of what the electrode looks like. It's got these what we call contacts, right? So where the electrical current comes out of. There's typically 4 to 8, depending on which system is used. And not that all of the contacts have to release current necessarily, but because the area in the brain where this electrode has to sit is so small, we have to make sure that there's no margin of error, right? The electrode placed in that small little 5 millimeter area, if it's a little too low or too high, we still have those contacts. At least one of them will sit just right for us to use and turn on. That's why there are multiple contacts. The current delivered to the brain is not continuous, but it's intermittent, right? So then you'll hear the neurologist speak about an amplitude of the current, meaning how strong the current has to be to make a difference. The pulse width, which is how long each pulse of these current pulses lasts, and the pulse frequency, meaning how many pulses of this current are being delivered a second. And after the surgery, it's not as easy as just turning it on and then out the door we go. There's thought that goes into optimizing the current being delivered to the brain in the same way you would optimize the dosage of a medicine, if you will. And at the same time, thought has to go into reducing the amount of medicine that one takes so that you reach that balance between what the DBS delivers and how much medicine you need with the DBS turned on. And that takes place over multiple visits and may take some time. When is DBS considered, right? So when does this enter the conversation in the clinic? I would say the conversation about this begins fairly early, just to sort of acclimate the individual, the person with Parkinson's, with the idea that there is this treatment available called deep brain stimulation, that's brain surgery, for certain problems that may arise down the road. So if or when we get to that point, it doesn't come out of nowhere as a surprise, but someone is already sort of educated and knows that this exists and what it does. Now, the timing of the surgery is different. So first of all, I would like to say that not everyone with Parkinson's will need or would benefit from this therapy. I'd say only about 20% would benefit from this surgery. But it is helpful in those moderate stages when there are symptoms that cannot be controlled with medications alone and the quality of life plummets. It is important to set expectations right from the beginning, meaning we have to make sure that the DBS is addressing the problem that bothers that person with Parkinson's the most. Because we might see that they have tremors, right? And DBS would help the tremor. But if the problem that bothers them the most is falling, and DBS doesn't address that well, there's no good rationale of sending someone for brain surgery if at the end of it the tremor is much better, but they keep falling, right? And their quality of life is not any better because they can't really get out of the house without the walker assistance. So it's very important to sort of have that conversation and understand what is that one or two things that are really affecting quality of life, and can that be addressed by DBS? That's number one. And then usually these decisions are not made by one person alone. When DBS is done, there's a team of people that come together and sort of discuss, whether or not the treatment is appropriate, the timing is appropriate, and what are the potential risks and potential benefits. And that includes the neurologist, of course, the neurosurgeon who does the surgery, a neuropsychologist who's involved in cognitive testing, which is important before surgery, and other specialties such as physical therapy, mental health providers if there's a need. So it depends on, again, each individual, but there's a collection of people that come together to sort of make these decisions along with the patient, of course. So I kind of touched on when would DBS be helpful, and that it's in the moderate stages, addressing these off symptoms and fluctuations. It is important for someone thinking about having DBS done not to have significant cognitive symptoms, because if someone has dementia or significant cognitive problems, then DBS would hurt more than help. So that's usually a reason not to do DBS. And DBS does not address, those non-motor symptoms, including depression or anxiety or severe constipation. So those are not reasons to do DBS. DBS can be used for severe tremors that don't respond to medicine well. Can also be used for Parkinson's disease symptoms in individuals that happen to be very sensitive to medicine. So there are situations where no matter what medicine we try, an individual can be so sensitive that they develop side effects before the medicine has a chance to help. So that restricts how much we can increase the medicine and how much we can do with medicine. So that's not a situation where DBS may be helpful. And we talked about dystonia, which are those sort of twisting, sometimes painful movements of a foot or a hand. DBS can be helpful there as well. We talked about who would not be a good candidate for DBS, and we talked about someone with dementia or severe cognitive symptoms, as someone who has major medical risks, meaning other medical illnesses unrelated to Parkinson's that would make them a high surgical risk. Someone who has severe or insufficiently treated mental health problems. Someone who has severe gait problems with falling and freezing. Those are not symptoms that respond well to DBS in most situations. And when the goals are a bit unrealistic, we have to be on the same page as to what DBS might help with and what it won't help with. Advanced age is somewhat relative. It really depends more on how healthy someone is. And we really have to make sure that someone has Parkinson's before we do surgery. The benefits are improved quality of life, and this has been studied quite extensively. Less off time, improvement in movement control, and need for less medicine. Risks of DBS fall in different categories. There are the immediate surgical risks, which are typically rare. Those are bleeding in the brain from putting the electrode in. Infection, which typically happens afterwards, again, fairly low, 5%, but definitely a risk. Very rarely the lead system, meaning the electrode in the brain, can be displaced or damaged. That can happen, for example, in case of severe trauma. And there are possible side effects related to the actual stimulation, right? So when we turn the DBS on, the current can sometimes go too far in the brain and lead to problems with speech or gait, can lead to being too effective and causing dyskinesias, believe it or not, or can sometimes lead to cognitive or behavioral symptoms. So it's not a risk-free treatment, and that's why we have to really be very careful about selecting the right people to have the treatment done, so we don't harm someone with Parkinson's more than help. We've had situations where there's a sudden the battery reaches end of life suddenly. Normally, once DBS is done, patients come to the clinic periodically to check the system, optimize the stimulation parameters, check the battery. We've had situations where people moved, or maybe people traveled, or maybe just people kind of forgot because they were feeling good and forgot they had it in, and the battery reached its normal end of life, which is typically 3 to 5 years. That can lead to problems, meaning a sudden return of previous symptoms, but sometimes worse than they were when DBS was done. The DBS evaluation process includes, again, meeting with the neurologist, discussing expectations, optimizing medications to ensure that there's no other option. There's what I call a on and off evaluation when we have to see the person with Parkinson's off their medicine to inventory the extent of their symptoms without the medicine, to fully understand the breadth of the symptoms and what seems to be affecting them the worst. And then they take the medicine and we reevaluate them that same day after they took the medicine. So we quantify the response to the medicine and see which symptoms responds, which symptoms doesn't, how much of response there is, because that helps us guide the decision-making process when it comes to DBS. We talked about someone having to be cognitively reasonably well to go through the surgery. So that's normally tested through neuropsychological evaluation, and everyone who has DBS for Parkinson's has to have this, so we know. And once all these prerequisites are met, then we engage the neurosurgeon. There's a meeting with the neurosurgeon to explain the risks, the procedure itself, the stages, the aftercare. There's a brain MRI that has to be done that helps in mapping where to put the lead in the brain. And of course, medical clearance from the primary care and all the specialists that one might see other than the neurologist. Just a quick, I don't want to run out of time, but just a quick word on where the lead is placed. There's several spots in the brain where that lead can land. That decision is made ahead of time depending on the symptoms or we're trying to address. So it's not just one place, but there are 3 potential places. There are 3 different systems available, not just one, Medtronic, Boston Scientific, and Abbott. There are different types of batteries. Some of them are a one-time use battery that they stay in the chest for 3 to 5 years and then they have to be replaced. And some of them are rechargeable, where it's like a phone. You recharge it once a week and you have it in for 10 or 15 years. So there are different types of systems. And for Parkinson's, the majority of people having this surgery will end up with leads or electrodes on both sides of the brain. It's rare that we do just only one side. And there are different ways of doing the brain surgery, DBS surgery, depending on the surgeon and the center, the hospital. There's what I call an awake way and a sleep way. Awake is when the patient's awoken throughout the surgery for a little bit to test the system once it's implanted before they go back to sleep. The asleep one is when they're asleep throughout the surgery. And what to expect after surgery. The recovery takes a few weeks. You have to see the surgeon periodically to make sure the wounds are healing properly and there's no infection. And then you meet with a neurologist, they turn the device on, and then there's this DBS programming or tweaking these parameters over time and readjusting the medications, which usually after DBS is turned on, there's less need of, or there's need for less medicine after that point. And what does life look like with DBS? These questions come up quite a bit. Can I swim? Can I fly? Can I, go to the gym? So the answer is yes, yes, and yes. There are very few restrictions after DBS. For example, MRIs is one of them. All the systems are now MRI compatible, but there's certain restrictions, meaning the MRI has there's clearance that have to be given before an MRI is done. There are battery changes every few years depending on which battery is implanted. It's important to carry an ID that identifies the fact that you have the system implanted and who's the doctor to call if there's an emergency, especially if you travel. And just the same way you would have with a pacemaker, like cardiac pacemaker. Any other sort of imaging tests like x-rays, CAT scans are okay to do, there are no restrictions. And be prepared for what both software updates. You know, these batteries implanted in the chest that power the electrodes are small little computers. And once in a while, there'll be updates, and those will be, the little computer has to be updated as well. I think I covered the fact that it's not a cure, but it improves our quality of life. And what kind of questions should you have for your neurologist if you're curious about DBS and if it's right for you or not? The first one is, how can DBS can help me, right? Am I a good candidate for DBS? What are the benefits and risks for me personally, right? And which DBS system should I consider? I want to touch upon MR-guided focused ultrasound in the last 5 minutes. This is another procedure, surgical, for treatment of tremors and Parkinson's disease that's FDA approved. This is much newer. It was approved probably in the last, for essential tremors in the last 4 or 5 years, I believe, and for Parkinson's in the last 2 or 3 years. And this is, I'm going to make this sort of statement from the beginning. This is not a widely used procedure for Parkinson's disease because it has a lot of limitations for Parkinson's. It is a much more widely used procedure for people with different tremor conditions, like essential tremor. But for Parkinson's specifically, it's valuable when someone has severe tremors or very one-sided symptoms, which is not frequent, or when someone would benefit from DBS, but they're not a candidate for other reasons. And this procedure essentially is an incisionless, meaning no skin cutting, technique consisting of lesioning a small part of the brain deep inside by using this ultrasound machine under MRI guidance. And it is approved for tremors in Parkinson's and also for fluctuations and motor symptoms, with a caveat that that it can only be done one side at a time. So as opposed to DBS, where we put the leads in, usually the same surgery or very close together, with the focused ultrasound, you have to do one side. You have to wait 6 to 9 months to make sure that the side effects are not, there are no significant side effects, and then you can do the second side if needed. Usually the side effects are mild and transient in most people, consisting of changes in speech, balance, maybe a little bit of weakness, and lack of balance, but those typically go away within 3 months or so. And I think that's all I have. And I will take questions.
But we have 5.
Okay. So first one is there research into the causes of onset of Parkinson's, and what could causes be? Well, this is a whole different lecture in its own right. The short answer is, what we know so far is that Parkinson's lies at the intersection between someone's genetic makeup and the environment. And it's not always the same for everyone. There are definitely certain genes that have been identified to be causing Parkinson's or to represent a risk for developing Parkinson's. That's usually the most common story is someone has a genetic predisposition because of their genetic makeup, but it's the environment acting on the genetic makeup that leads to developing Parkinson's. And environmental factors that can lead to Parkinson's is wide. I mean, they're wide. That can vary from, of course, pesticides, which have been the most studied environmental toxins that can lead to Parkinson's, but so is head trauma or repeated head trauma, head injuries, There have been studies looking at air pollution potentially contributing to the risk of developing Parkinson's disease. So many, and I think the research is definitely ongoing in both the genetic risks and the environmental risks. So that's kind of where we are. Family history of Parkinson's in someone who developed Parkinson's is not as common as you'd think. If there's a family history of Parkinson's, that can increase the chances of developing Parkinson's, but it's not a given that just because you had a parent or a sibling with Parkinson's, you would develop Parkinson's. The risk is still small, even though it's a bit higher than when there's no family history. Next one is, are there any advancements being made for Parkinson's patients with dementia? So I would have to say this is an area that needs a lot of where research is badly and sorely needed. I would say that the dementia in Parkinson's is a little bit different than dementia in Alzheimer's disease. Although the two can sometimes coexist, and as many of you may be aware, we've made progress with therapy for Alzheimer's disease dementia, meaning there are medications available now that would slow down progression. We haven't gotten to that point with Parkinson's disease dementia yet, but I think that once we reach a point where we have treatments available to slow down Parkinson's disease progression, I think treatments for dementia Parkinson's will follow. But I think we need much more research in that. I'm going to have to read this later on. I'm not understanding the handwriting well, so I'm going to go back to this one.
Must be a doctor.
That's right. What medication is recommended for hallucinations? So, a few points on hallucinations. So hallucinations are symptoms that can happen in Parkinson's where our eyes or ears or skin can play tricks on us, right? So we may see things that aren't there, we may hear things that aren't there, we may feel things that aren't there, so those are what we call hallucinations. More often than not, these are side effects of medication. So when someone brings up hallucinations, the first thing we do is look at their medications, because more often than not, reducing dosages or eliminating certain medications can help the problem, can take care of the problem before we add medicine to treat hallucinations. Now, sometimes hallucinations happen anyway, medicine or not, especially in the setting of dementia. And in those situations when we have to treat them, and there's no medicine we can take away to make things better, there are medications like donepezil or rivastigmine. These are medications that work on a chemical called acetylcholine in the brain. Those are milder medications, and if the hallucinations are severe and affect someone's sense of reality, we sometimes use antipsychotics, although most antipsychotics are contraindicated in someone with Parkinson's, most of them. There is a select few that are safer, and we use them quite frequently. I'm going to name them, although they have kind of weird names. One of them is called quetiapine. You might hear it as the brand name is Seroquel with a C, with an S. The other one that's the only FDA-approved antipsychotic for treatment of psychosis in Parkinson's disease is called Nuplazid with an N. That is the brand name. The generic would be pimavanserin. And very rarely we use another medicine called clozapine or clozaril. That's usually a sort of last resort. But these would be the antipsychotics we use if we absolutely have to treat hallucinations. besides medicine, are there any natural products that can help? I would say that if I had to pick one, that would be, thinking about the relationship between gut and brain. There have been research done, and I think that's kind of in its infancy, researching the effect of, or how the gut affects the brain. And now we know that Parkinson's disease in some people starts in the gut, and studies have shown that the same changes we see in the brain in Parkinson's, we actually see in the gut. And sometimes that's where the problem begins. And it's not uncommon to have a lot of gastrointestinal symptoms like constipation, lazy stomach, bloating, things like that. And research has shown that there's an imbalance between the good bacteria and bad bacteria in the gut. And is that imbalance and the overgrowth of bad bacteria that leads to inflammation and toxins being sort of spilled into the bloodstream and affect the brain. So it's important to address those gastrointestinal symptoms. One way is with probiotics. There have been studies looking at probiotics and their effect on Parkinson's. So in that sense, there's probably the one non-medicine related help that's available. And then the other one is exercise. I mean, that's probably the only intervention that can slow down progression, and exercise. We can't prescribe exercise, we can strongly advise it, right? Unfortunately, we can't write a script for it, but it's critical. It's one thing that one can do to make their life better and slow down progression. So the last question is, are there adjustments of DBS depending on the side of the brain, and if there are different degree of symptoms on each side? So I guess the question is, can we adjust the DBS settings or parameters independently on one side or the other depending on the symptoms? The answer is yes. I mean, Parkinson's affects the brain and the body unevenly. It begins on one side usually. It tends to be worse on one side than the other. Some symptoms may be more pronounced on the right, while some other ones may be more pronounced on the left. So we can definitely make adjustments on the right side, independent of the left side, trying to address different symptoms. So for example, one might have more tremors on the right, but may have more dyskinesias on the left. So those would require different programming or setting strategies, and we can definitely do that with DBS. And I'm trying to read the last one, the doctor's handwriting. Are you involved with cause research as all right. Well, I think that's all I had. I'm sorry. I couldn't read the last one. So thank you very much for making the trip here today. And I only got overtime by 3 minutes.
You're welcome. Thank you.
Thank you, Dr. Adam. And thank you all for attending. And just a reminder, we have a QR code in the center of your table. In addition to that, we also have surveys, so please fill out the surveys. You've all been very helpful in our past speaker series, giving us feedback on a number of different activities that take part in these programs. And so we want to hear about the subject matter. We want to hear what you want to learn about, and help us do our jobs better by helping you. My contact information is on the back table, as is our LSVT Big and Loud staff. And if anybody didn't get their question answered, feel free to ask that question. But thank you very much again. Have a safe trip home.